Today on the Wealthy Podcast, we're diving into a topic that touches so many lives: fertility and reproductive health. My guest is Dr. Kathy Wise, a distinguished fertility specialist and medical director at Olive Fertility Clinic here in Kelowna. Whether you're thinking about starting a family, navigating fertility challenges, or simply curious about the science and trends shaping reproductive health today, this episode is for you. Join us as we explore the realities of fertility, break down misconceptions, and share practical advice for anyone on this deeply personal journey. With years of experience supporting individuals and couples on their journey to parenthood, my guest today, Dr. Kathy Wise, brings deep expertise and compassionate insight to a topic that is so central to our lives as human beings. Fertility is undoubtedly a key aspect of health, perhaps one of the most that is taken for granted until that time arrives when we want to start a family, and it's proving to be not as easy as we thought. Infertility rates are on the rise, and fertility specialists like Dr. Wise find themselves busier than ever. So why are more individuals and couples struggling to conceive? And what factors are contributing to this trend? From the impact of delayed parenthood and lifestyle factors to the rise in conditions like PCOS and endometriosis, Dr. Wise sheds light on the complexities of fertility and why it's about far more than just getting pregnant. Welcome, Dr. Wise.
Thank you for
Can I
having
call you
me.
Kathy?
You sure can.
Okay,
Please
amazing. So Kathy, we have an opening tradition on the Wealthy Podcast. All of the people that end up sitting in that chair come to the conversation having, like you, a deep connection to health and healthcare. Can you share how you got here? What was sort of maybe your first awareness of health and healthcare, why it's important, and maybe why it's so important to you?
Great question, one I haven't reflected on in a long time, to be honest, Shauna. But I think I have almost a little bit of a cliche story there. I knew at a very young age, I was a teenager when I decided I was going to be a doctor. And I got that in my head and I stuck to it all the way through until today. So there was a little pivotal moment when I was a kid playing with my cousin in the backyard, and we were swinging a croquet mallet in the backyard. And he took a big backswing right into my head. And so I ended up with a good gash that needed some stitches. And so off we go, my parents and I, to the hospital for these stitches. And I said to the emergency room doctor that he could stitch my head. I was okay with that, but only if he let me watch.
Oh, wow.
And so he actually set up a mirror. So he covered me and put this mirror over top of my head and froze me and stitched me up. And I watched. And I said to my mom after that, this is what I'm going to do.
Really?
And then I did.
Good
so
for
kind
you.
of a funny story.
Wow, that's amazing.
I don't know why I wanted to watch, but I did.
Yeah, but that's telling.
Yeah.
Interestingly, my daughter is a teenager right now, but she has always been, like, from a young age, fascinated with, like, I think she's going to get into like physio or something. Similarly, like injuries. Like she always like for Christmas one year, she asked us for a pair of crutches.
Right.
Actually, she asked us for a pair of crotches, but we corrected her. But it's interesting how sometimes there's just a knowing within us, right? And a curiosity. It's like an itch you have to scratch, and then you just end up chasing after it. So what did that look like for you after you sort of decided you wanted to be a doctor? Did you know you wanted to be this kind of a doctor?
I definitely didn't. And I think a lot of physicians and med students right now can relate to this. Mm-hmm. You kind of go into medicine maybe with some preconceived notions, but you really have no idea what you're facing until you're in it. And then it morphed and it changed several times over the course of years, including my current career. So it just was a journey, and you have to experience things and you have to live them, and you have to see what your passion is and what you're drawn to.
Mm-hmm. So how did that happen? Like, did you, when you were, say, in med school, sort of, I know you have to sort of do a rotation through all sorts of different areas and specialties. Did you start off saying, okay, I want to be like OBGYN, or like, how did that go for you?
At some point, I realized I was drawn to things that were a little bit more procedural, tying back to my stitches as a kid, and surgical. So I shifted away from some of the more maybe traditional thoughts around family medicine. At one point, I thought about pediatrics, all these other areas, and realized, no, I'm interested in surgery. When I did my OBGYN rotation, I loved women's health. I loved labor and delivery. I think most of us do. And then there was also that surgical piece that I don't think I appreciated and I was really drawn to. So after I did a couple of rotations in obs-gynae, that's when I knew that was the direction for me. As a gynecologist specifically, I mean, we are surgeons, but it is female reproductive surgery that we do, right?
Okay.
So we do pelvic surgery, basically. That is actually more diverse than you would think, and I won't go into a lot of detail, but suffice it to say that it's sort of a niche area of surgery, but there's a lot of elements to that you can focus in on. And students will get exposure to that. Like, even if they're feeling like they don't know what the possibilities are right this minute as they get started, they will get plenty of exposure to decide whether that's a good pathway for them or not. And in medicine in general, never mind gynecology, there's so many other fields that are surgical that you could look at: generalists, orthopedics, plastic surgery, so many different things. You just have to decide if you're a person who likes to work with their hands in that regard, or whether your interest in medicine is a little bit towards the
more
other
hands
health
off
side.
Yeah, totally. Awesome. So let's kind of dive into the topic that you're here for.
Yes.
I feel like there is a lot of conflicting information out there with regards to fertility.
There's a lot of myths.
A lot of myths. Yeah. Or things that we think are facts, but in fact are myths.
Exactly.
So like, I thought we could do like a little bit of a rapid fire, true or false.
Great.
Okay.
Yeah.
And then we'll kind of get into the context of the answers that you give me. So, true or false? Infertility is always a women's issue.
False.
If you're healthy, you won't have fertility problems.
False.
Oh, I see a trend here.
Yes.
You can get pregnant at any age with IVF.
False.
Stress causes infertility.
False.
Oh, I thought that might be a tricky one. Having regular periods guarantees you're fertile.
False. Shauna, there's got to be a true on this list.
I don't know. Birth control causes infertility.
False. I really want to circle back to that one.
Okay. This one. You only need to worry about fertility after trying for a year.
False, but it needs elaboration for sure.
Okay. Then we'll circle back to that, because I feel like that's one that we hear a lot. Try for a year, and if you still can't get pregnant, then we'll talk about fertility issues.
That's not wrong, but I want to dive into the language there a little bit.
Okay.
Because you framed it a certain way, and I think it's a really great point to make.
Okay. Then we'll come back to it.
Okay.
So far, we're all false.
We're all false.
Finally, lifestyle changes will help with infertility.
That has to be a true or false answer. I'll say true.
Yay, I got one.
I'll say true.
It was actually phrased a different way in my notes, but I changed it so that I could get a true out of that. So lifestyle factors and lifestyle changes can absolutely have an impact on your fertility.
Yeah.
Okay. So I mentioned, let's get into it.
Yeah.
I mentioned the rise of infertility in my intro. This was sort of I've heard this. I think I've seen stats on this. Maybe it's anecdotal. But can you give us sort of a state of the nation overview on fertility when it comes to the Canadian population, or just sort of in general, what we're seeing in in terms of the trends with regards to fertility?
Yeah, you're absolutely right. It is a downward trend, and it's alarming. In Canada, we've had the lowest fertility rate ever for 2 years running. And Canada now is in a group of a number of countries with very low fertility rates. So we are now in the lowest of the low group, which is not good.
And by fertility rate, I'm just going to roll back.
What that means?
Yes. What does that mean?
So that is how many children per woman.
Got it.
Okay.
Okay.
And so when we look at British Columbia specifically, we are the lowest in Canada.
Wow.
Our fertility rate. Yep. Our women are having on average 1 child.
Interesting.
Yep. And that is the lowest. And that is not a replacement rate. We are not going to replace our population in Canada or in BC at that rate. So it's really low.
And so there are, I imagine there are a number of reasons why that rate is so low. Let's talk about kind of just in general, what is impacting that fertility rate?
So the number one thing, and you're going to hear me say this a few times today probably, Shauna, but the number one thing is delayed childbearing. We are putting off having our children for a variety of reasons, right? Women are wanting to seek higher levels of education. Women are wanting to pursue their career. Totally understandable. We also see that our young people are a bit hesitant to have children. They're expressing their concerns with, financial instability, cost of living, housing crisis, just feeling that uncertainty, that global uncertainty when you look at what's happening in the world nowadays. And I reflect on the news in the last couple of days with this terrible disaster unfolding in LA. That is in the news all the time now. And I think our young people are looking at that and thinking, is this the right time to have children? Should we be having children? And if they are, they're putting it off. And we know that the number one cause of infertility is advancing age and essentially waiting too long. So I think that's the reason we're seeing this.
Yeah. And I reflect on what you're saying, even just in my own case. I had my first child at age 30. I had my second at 33, and I wanted a third, but the power of veto, my husband was like, we're good. But that, I think that's probably like on the older side, but not the oldest. What's the optimal age? And I know it probably is variable, but I'm sure there's an optimal age for fertility.
Yeah, I would say ideally under age 35.
Yeah.
If you have a target, it's under age 35, you are most likely, not always, but most likely going to be able to have children if you're under 35. If you are 30 and under, you're even more likely to be able to have children. But a lot of women are waiting until their later 30s and even early 40s now.
Yeah.
And so I saw an interesting statistic, and it was saying that the average age of women having children in 2023, I think it was somewhere around 32 to 33.
Oh,
right?
wow.
Right,
yeah.
your age when you had your second.
Yeah.
If we look back 30 years, 1993, it was significantly lower, and before that, even lower still.
Really?
Right?
So into the
there's
like
definitely
20s.
a trend here.
Yeah, and you can certainly understand it, like advancements in, I don't know, would you call it a hormone technology, but the oral contraceptive have allowed women a little bit more opportunities to pursue higher education without the concern
Freedom
around
of choice.
Exactly. Yeah. So, which are good things, right?
Yes. Yeah, absolutely.
But at the same time, you can't sort of fight against biology. The fact is that we're best suited to be having babies as women probably in our 20s.
Age.
Yes.
Yeah.
So,
unintended consequences. How many times have we heard that lately, right?
Yeah.
Where it's technology advances and there's amazing things that come from that technology, but there's consequences that we don't always reflect on.
Yeah. And they are very downstream, right?
Mm-hmm.
So let's kind of like roll it back a little bit then. So as we age, you mentioned that as women age, they're less likely to conceive, right? Or might have a little bit more of a difficult time. Can you explain what's happening? I know you're going to understand this question, but I want to be clear. I want to know what has to happen inside in order for a woman to conceive a child. We all know about the other part.
Perfect. This is great. So we will go to, reproductive biology 101. Here we come.
Yes.
So fundamentally, we have to have certain things happening in order to get pregnant. So we need ovaries and we need eggs. And we need to be able to release an egg on a regular, usually monthly basis. We need a conduit for that egg to meet a sperm. And that is our fallopian tubes.
Okay.
So we need at least one open functioning fallopian tube.
And we have two.
Yeah. And we need a uterus that is ultimately going to play host to this little developing baby. So it needs to be also healthy and functional and capable of carrying a pregnancy. And then ultimately, we need sperm along the way as well.
Mm-hmm, mm-hmm.
The thing that happens with reproductive aging, as I like to call it, we're not getting old, but it is still reproductive aging, that I think a lot of us don't understand, is that women are born with all of their eggs.
Mm-hmm.
So we are born with, let's say, 1 to 2 million eggs. Your peak egg count actually was in your mother's uterus. By the time you were born, you had already started to lose eggs. And then as we go through our reproductive lifetime, we just continue to lose eggs at quite a surprising rate. Because if you do the math and you think about puberty and then puberty to menopause, and we release 1 egg a month for our lifetime, generally speaking, doesn't add up to 1 or 2 million. So we lose eggs every single month, every single day. But of the eggs that are remaining, those are the ones that are available to us to be able to become pregnant. And those eggs are exposed to the environment and also going through a natural aging process through our entire reproductive lifetime. Mm-hmm. So by the time we reach our mid-30s, those eggs are not the same biologically as they were at 20, 25. They are not as fresh. They are not as viable.
Right.
And so as a result, it can become very difficult to conceive. And then we're individually different. So not every 35-year-old is the same.
Right.
Someone is going to be able to get pregnant quickly and easily, and that's amazing. And then I'm going to meet a 30-year-old who is struggling to conceive, and it may still be an egg quality problem. And I think there's this misperception that as long as we're having regular menstrual cycles, to your question,
right,
and even maybe that you're healthy, to your question, and well, and looking after your body, that it should be no problem. But unfortunately, the quality and the characteristics of those eggs, that's beyond your control. Not all of it, but for the most part, it is beyond your control. And so that is what will often drive whether or not we can conceive.
Interesting. So really, truly, like I don't want to say number one factor, because I know it's multifactorial, but it's a huge part of our fertility is how old we are or how fresh our eggs are when we make that decision that we want to.
It is the number one factor.
It is the number one.
There is no question. It is definitely the number one factor.
Yeah. Very interesting. And, we hear like the topic du jour is like, for me, I'm perimenopausal. So I'm on the other side of all of this, but like all the stuff about hormones and all that is so topical right now. But it's also really topical when we're talking about fertility. Like, what role do hormones play in the whole process? And back to kind of one of my original questions, a lot of women have experienced the benefits of oral contraception, but it is a synthetic hormone. Does that have an impact? I think that's a huge thing that people want to know. If I'm on the pill for 15, 20 years, am I going to be able to conceive?
We know that the birth control pill does not cause infertility. We do know that.
There, you heard it here. Yes.
What does cause infertility, as we just discussed, is waiting too long.
Okay.
And there's correlation there,
Right.
but not causation.
Okay.
It is not the birth control pill that caused the infertility. It was the choice to, of course, have good, reliable, safe contraception for many years while you pursued other important life things and goals, and waiting to get pregnant, and then stopping the pill because the time was finally right, and discovering, this is not as easy as I thought it would be.
It's not. It's not
is
the
the
pill.
correlation, but it is not the pill.
Yeah.
With respect to hormones as it relates to fertility, hormone therapy is one thing. And when we talk about hormone therapy, we usually mean hormone replacement therapy in a menopause. But oral contraceptive pills are a form of hormone therapy. And obviously, they will not allow you to get pregnant because of the way they work in the body. But with our natural hormones, our hormones are sort of an intricate communication system between the pituitary and the ovaries. The pituitary is a gland in the brain that is command central for the ovaries. And those two talk to each other hormonally. And those hormones have tremendous cyclic variability. What I mean is the range of normal is incredibly vast.
Right.
And it depends on where you are in your cycle and what the pituitary and ovarian agenda are. What are they trying to accomplish in terms of those hormone levels? But they need to communicate in a very specific pattern. They need to talk to each other in a consistent, regular way in order to get us ovulating each month. And so that's how our natural hormones drive ovulation and sort of dictate our fertility, as it were.
And I think that's super valuable to understand, because I'm learning that there's all sorts of things that can disrupt that conversation, right? So we talked about stress, we talked about sort of other lifestyle factors. It could be maybe diet, not eating enough, over-exercising, whatever. I'm just prattling off things that I think I know. What are some things that can disrupt that? What I say is like a very intelligent but delicate conversation between the pituitary and the ovary.
So the things that you mentioned, there are definitely lifestyle factors in the extreme, I'll say, Shauna. So most of us will continue to have normal pituitary ovarian communication despite stress, normal life stress, a difficult job, situational stress. But sometimes in extremes of stress, even for a brief period of time, we can see the menstrual cycle disrupt. We can see our period become irregular or our period stop happening. We can see that with athletes.
Yes.
So women who exercise to an extreme, and that tends to be tied to having a very low body fat percentage. We can see that with eating disorders. So again, extremes. We can see it with obesity. It's another reason that our menstrual cycles and our pituitary ovarian communication may be disrupted.
Right.
Subtler things, if you like a certain type of diet or you're vegetarian, you do intermittent fasting, some of these things that are fairly popular, they would not necessarily disrupt that communication balance.
And I think that's really helpful to know, because if a woman is experiencing irregular periods, is that normal? Is that a normal thing, or is that a sort of a cause for kind of like, something's up?
It's not normal.
Right.
We should be having regular periods. It's certainly common for a variety of reasons. So the questions become, how long has that been going on for? why do we think that's going on? But there is a why. We need to figure out why that's happening. And ideally, we don't want women to have irregular periods for very long, whether they're trying to conceive or not. But certainly when they're trying to conceive, we need regular, consistent menstrual cycles, because that is highly predictive that you are ovulating.
Right. The indicator that you're ovulating is
yes.
having a bleed, right?
Regularly.
Because then that's the, I don't know, that was, for me, it was like, oh, okay, things are working, right? But I didn't know that not having a regular period, like mine has always been, I'm really sharing a lot on this podcast, but I've been very regular. But I had a person in my life who was really irregular. Turned out that there was an underlying condition.
Yes.
Yeah. And we're going to talk a little bit about that, because those can be also, like, I think like the, you know, if there is irregularity in your period and you're sort of past the first 3 years, let's say, of when you start menstruating, it's sort of a red flag.
It's a good idea to have it assessed.
Yeah.
Not necessarily a red flag. It may be something that's quite easy to explain and quite benign, but you want to understand it.
For sure.
Yeah.
So let's talk about some of those things that can, that irregularity might be an indication of. Another really important topic that is finally sort of seeing the light of day, PCOS, or polycystic ovarian syndrome. I imagine this is a big part of your practice. Can you talk a little bit about PCOS?
Yeah, PCOS may well be in the limelight right now. It's always been in my limelight, so I can't speak to what's happening in the general public. But one of the blessings and perhaps curses of the internet, social media, is that a lot of these topics are getting the attention that they deserve.
Exactly.
So polycystic ovarian syndrome is one of the biggest misnomers that we have, but it is a relatively common diagnosis, and it is the number one cause of irregular menstrual cycles. The reason it's a misnomer is the word cystic.
Right.
So PCOS and the cystic gets women thinking that they have a bunch of ovarian cysts, and they do not.
Okay.
It actually has nothing to do with ovarian cysts, although ovarian cysts are common. You could have an ovarian cyst with PCOS, but not necessarily. PCOS means you have an abundance of egg follicles in your ovaries. You have actually lots of eggs, but that communication that we talked about between the pituitary and the ovaries, that is not happening properly or consistently for very complex endocrinologic reasons.
Right.
That is a whole podcast in and of itself. So they don't talk to each other properly, but you have an abundance of egg follicles. What we're missing is the regular maturing and ovulation of those eggs. So there is a tendency to not ovulate or not ovulate consistently. In addition to that, our ovaries make other hormones, not just sort of estrogen and progesterone, which are the ones we tend to think of. Our ovaries make testosterone as women. When you have many follicles or eggs in your ovaries, one of the things you overproduce is testosterone. And so we get some physical effects that can go with that high testosterone level and PCOS. So PCOS should have been called polyfollicular ovarian syndrome, would have been a much better name for that condition. But it is not always going to result in infertility, but it certainly is a risk factor for infertility. Some women with PCOS do ovulate and do get pregnant within a normal time frame, within a year of trying to conceive, and others will struggle to conceive and need help.
And my understanding is some women do know that they have PCOS, but many don't until they make the decision that they want to start a family, and then are having challenges and discover then that they have this condition. But my understanding is there are some indicators in addition to the irregularity of a menstrual cycle that can kind of give someone the heads up that this might be happening for them? Can you kind of outline those?
Yeah, it is the S in the PCOS stands for syndrome.
Right.
So it means that it is not just one thing. It is a combination of things that leads us to believe a woman might have PCOS. But common indicators other than just the irregular cycles would be physical signs of the higher testosterone levels. So the most well-known one is increased dark, coarse body hair. As women, it's often where we don't want it. Chin,
Right.
upper lip, chest, back, not fine peach fuzz hair, but that I'm starting to get a beard or a mustache.
Okay.
Acne. So not, again, sort of common teenage years acne, but acne that is above the average and persistent, acne on the chest, acne on the back. Some women with PCOS struggle with weight. So it is very common to be overweight, but that is not necessarily always the case. Those would be the things to be aware of, I think.
Okay. And I do think that is helpful. Is it possible too also to have PCOS and not have those things?
It is.
Yeah.
Yeah. There are some, PCOS is a giant spectrum.
Yeah.
And so some people have all the symptoms that you would read about in a textbook, and others have one.
Yeah.
And very few. So yes, there is no cookie cutter for that particular diagnosis.
I find the body and physiology fascinating because on one hand, it's like, yes, there are some things that are sometimes consistent, but sometimes they're not there.
There's exceptions for sure. Yeah.
And I did just learn recently that you can be, like a healthy normal weight and still have PCOS. Because I always thought it was like, it was more kind of the overweight was an indicator of PCOS, but it is, but not all the time.
Common, but not all the time.
Yeah. Okay. And now I'm going to ask you about a topic that is very close to my heart. I have a person in my life who's super close to me that has stage 4 endometriosis. And I have walked alongside her on that path for almost 2 decades. And it has been a very long, hard one. And I'll try not to get emotional, but one that she has felt very alone on. She was fortunate in that she was able to conceive through IVF, but that was also hard. And we're going to talk about all of those options. But I still feel like endo does not get its due attention. What is endometriosis? And can we talk a little bit about how that impacts a woman's ability to have a baby?
So endometriosis is a condition whereby tissue that would normally be the lining of the uterus, what we call the endometrium, manages to get outside of that uterine environment and set up little implants in other parts of the body, most commonly the pelvis. So a woman who has endometriosis will have multiple patches of tissue or spots of tissue scattered in various locations in the pelvis and even sometimes other parts of the body. And those implants of tissue are highly inflammatory. And so it's a chronic inflammatory disease. And the hallmark is pelvic pain.
Right.
Pain with menstruation, pain with intercourse, pain with ovulation sometimes, and sometimes just pain. And we don't know why some women get it. It's very complex, and there's a lot of research that goes into this, but we still don't understand exactly who gets endometriosis and why. And it's also a very difficult diagnosis to make. And this is the crux of the problem.
Because you can't really see it unless you go in there.
Can't see it.
Yeah.
So the only way to confirm a diagnosis or a suspicion of endometriosis is you have to have a surgery where a gynecologist puts you to sleep and puts a camera in through your abdomen to look inside the pelvis. Not an easy simple thing to do. So we often speculate about endometriosis, but we may not be certain. And endometriosis can masquerade. It can present as bowel symptoms.
Right.
and other forms of abdominal or pelvic discomfort. And so it's easy to dismiss. It's another condition that is a risk factor for infertility. It doesn't mean you will be infertile, just like PCOS doesn't mean you will be infertile, but it means there is a chance you may struggle to conceive because of that diagnosis. So it's good to be aware of that connection as well.
And the way it's interesting, as you were describing endo and how it presents in a woman's body, oh my gosh, I went down this, like, as you mentioned earlier, right now, we're all watching in horror what's happening in the U.S. and California with the wildfires. And I was watching, there's so many of these videos of people that are fleeing the fire, and you see the wind, and it's like blowing these embers. It's like blowing these embers from the fire, and they're just like lighting up all over in other spaces. And that's how, when you were talking about endo, that's how I imagine endo is like, it originates in the uterus, but it's like this, the embers of tissue are just blowing into other areas of the pelvis where it's not supposed to be, and lighting them on fire. Because like my person that has this, that's how she talks about it. She's like, it's like it's on fire.
Yeah. Great analogy. I love that analogy, actually.
Yeah. And is that kind of how it is?
Yeah, I think that's a great visual. Endometriosis can be even more diffuse. Rather than embers, it can be
like a
big bushfires. There can be big, patches of endometriosis tissue, lots of scarring because of the inflammation. It causes scar tissue, and that's one of the ways that it can negatively impact fertility. Scarring of the fallopian tubes, scar tissue around the ovaries, surfaces get stuck together, and they don't have the natural mobility that they're meant to have. And it's also just a bit of a difficult environment for egg and sperm to find each other. I can draw on your fire analogy and those winds that are blowing embers everywhere. I mean, imagine
it's hostile.
Yeah, imagine that this lovely little sperm and egg are trying to find each other in that terrible environment. It is very much like that. So that's a great comparison, I think.
So how would a woman sort of differentiate between, your regular garden variety? I've got, Aunt Flo arrived, and now I'm like, it's got a little bit of cramps and it's bleeding and this and that, between sort of that and endometriosis.
Sometimes you can't.
No.
So endometriosis can be subtle. There are women that have it that never knew.
Right.
So again, it's a confusing condition because the amount of symptoms doesn't necessarily match the amount of disease or the impact. And so menstrual cramping can be just that, just bad luck menstrual cramping.
Right.
And sometimes it can be endometriosis. So that's the crux of the problem, Shauna, is that we can't tell necessarily what it is. So maybe for listeners, it's about having some awareness, and just circling back to the fertility piece is understanding that if you're struggling to conceive, here are some of the things to be aware of or to be thinking about. But that's not an easy diagnosis to make.
And certainly it's the suffering I've seen when it is extreme. Again, I think I've probably had the experience on the extreme end of it. It's a really serious diagnosis.
It's a heart disease.
A really serious disease. And for those people that are listening that may be suffering with endo or PCOS, just sending love, because I know it's not an easy journey.
It's not easy.
Yeah. So I kind of want to, before we get into, there's light for women that are deciding to have a baby at 35 or, you know, may have been struggling with some of these conditions. But back to my true false. It's not always a woman's issue.
It's not. It does take two to tango for sure.
Yes.
So yes, this can be a sperm problem.
A sperm problem.
Yeah.
What are some of the sperm problems that one might encounter?
Anything really.
Yeah.
I mean, we can see low sperm counts. We can see low sperm motility, which is how well they swim. We can see abnormal sperm production, hormone imbalances for men. All kinds of things can affect sperm and sperm health.
Are there lifestyle factors for men that cause that? Some of those things?
Yeah, similar to women, right? So we have to be mindful of our diet and activity levels. Smoking hasn't come up yet. Smoking is a number one environmental toxin for eggs and sperm.
Do people still smoke? Is
do.
that a thing?
They do, and they see me.
Yeah.
So for
and
the smokers out there,
you could probably stop smoking.
Yes.
Okay.
It's a big one.
Okay.
Marijuana.
Ah.
So since we've legalized
that is a thing. Yeah.
We're going to be able to get more and more data, but the data that's starting to come out with respect to the impact of daily, so regular marijuana use and fertility is not good.
For men specifically
and
or
women?
Both?
Yeah,
okay.
Sorry, I digress. It's not men specific, it is both. But yeah, all of those things can certainly impact sperm and male fertility.
Interesting. What about I'm just gonna go there, like tight bike shorts or anything that squishes things up.
I haven't seen anything too compelling on that.
Right. So
I
you
have
don't have
to
say,
say,
wear boxer shorts.
I don't have more cyclists in my practice, and there's a lot in the Okanagan.
Yeah,
so,
okay.
You know, I think certainly when couples are experiencing infertility, that's when we get a bit more picky.
Yeah.
Right? We start to say, okay, this isn't working easily or quickly. So, men, avoid the hot tub, avoid the sauna.
Okay. Right, got it. You
don't wear your
heat
tidy
up the
whities.
guys. Okay.
Put on the boxers.
Okay, see, I'm not completely
Nope,
out to
it's
lunch
not
on
crazy.
That. Okay. Yeah.
Take your phone out of your pocket. This is the
right.
latest, is the heating up of the phone
and
any other emissions. But to be fair, other than the heat has some pretty good science behind it, the superheating. But these other things are sort of subtleties that we're not sure how much of an impact they have, but it seems reasonable that if things are not working in a timely way, that you might want to make some of those modifications.
Okay, and I have one more question because settle a little, I don't know, it's not really like a debate that we have, but oh boy, this is personal. Do you, if you're having sex more, is that better?
It's not wrong.
Okay. This was my husband's whole pitch. Well, we were in that phase of our life. It was like, more is good. Okay.
There can be too much of a good thing.
Okay.
So I will say that multiple ejaculations in a day are going to drop sperm counts.
Okay.
So that is too much.
Okay.
But generally speaking, we tell patients, couples, you want to try every couple of days.
Okay.
Every 1 to 2 days in that fertile window. So that's the window sort of just before and after a woman thinks she's ovulating.
Okay.
Yeah.
Good. Okay. Good news. Good news for all sides.
There you go.
I think. Yes. And kind of the last question before we get into some of the solutions. All of the biology and the data factors aside, there's a lot of emotions associated with this. When a couple or an individual comes to you and says, I want to have a baby, and it's not happening, what do you say to them?
Oh boy, what do I say to them? It's very individualized, Shauna, so I'm not sure that I can articulate exactly what I say.
Well, maybe what are they usually feeling?
But they are profoundly sad.
Yeah.
And frustrated and discouraged. I think a lot of folks who are going through infertility feel broken.
Right.
Trying to, being able to have children, as human beings, we see that as a fundamental human right. And not only that, a need, right? For a lot of people, that is just at a gut level, that's something they have always wanted and needed in their lives. When it's not happening, the emotional toll is profound. It is massive. And they feel alone and quite isolated a lot of the time. It's really tough.
And there has been stigma around it because, as you said, we sort of just assume that this is the way that nature is and it's going to work. And when it doesn't, when you said broken, that's not just an emotional term. It's like, I'm actually broken as a human.
Yeah. And that's not something you talk about very easily, right? As you can imagine, that's a very hard thing to express to people. And it's also ties into the most intimate part of our bodies, our relationships. So these aren't things that we certainly historically have shared, and I would say even continue now to not share very easily.
Exactly.
And this is where there's been, huge benefits of the internet, social media, podcasts, blogs. There is a lot of sharing now, and that's fabulous, but nonetheless, that's not what everybody needs or wants.
Well, and I think it's different to, it's good to feel a sense of validation, or that, like you said, a lot of them feel like they're very alone. I don't know if, I think it might feel validating to hear that others are sharing this story, but, or this experience, but I don't know if it would necessarily take away the sting that it's affecting you personally. Yeah. So what can we do?
So continue to talk about it. Continue to educate our patients and make sure we're educating women especially about the realities of reproductive aging and how critically important that is. My message to listeners and to anybody I can reach is, please just ask questions, have dialogues, talk to your care providers. Even that's challenging nowadays because so many of us don't have a primary care provider that we can go to. But you can talk to a walk-in doctor. You can talk to your neighbor. You can have conversations around what resources are available and seek help. If you are trying to conceive and it's not working, and we'll talk about the timelines here in just a second, then make sure you're asking to see an obstetrician gynecologist or someone like myself, where our focus is just fertility medicine. And what I would say is, if you're under 35 as a woman and you're trying to get pregnant and you haven't got pregnant in a year, this is where this comes up. That's a good time to start asking for help.
Under 35 and you've been trying for a year. Yes. Okay.
Time to look into it a little further and see if something is going on or if there are some options to help you to speed things up. If you're over 35 or 35 and over, I will say, I would shorten that time frame.
Right. Okay.
I would bring that down to 6 months. Why? Because as we age, it gets harder, and the sooner we can help you, the better. You don't want to keep waiting. You want to seek that assistance sooner rather than later. And if you get pregnant naturally in the meantime, fabulous. But at least start having those conversations and looking for help.
Yeah. And if there's anything that we have sort of championed on this podcast since its very inception, it's that we all have to be our own champions of our health. And no one is going to do it for us. Those days are over. We have now, with the internet, it's a vast resource of information. Some of it is good and some of it is not. But at the end of the day, taking responsibility for our own health and fertility is the best way forward. Yeah.
And advocate for yourself.
And advocating. Yeah. I don't want to, undermine our an amazing healthcare system in many, many ways, but there are gaps, and be noisy. So we'll leave that there. However, I do want to talk a bit about some of the solutions that you present, because it's not a closed book. If somebody is not, thankfully for, modern science and technologies, there are options for couples and individuals that are looking to start a family that are having trouble. And so what are those?
So there's a huge range of things, but just to give you kind of an overview, we have different fertility medications, as I call them. So there can be oral medications that can assist with ovulation problems, such as the PCOS patient. And sometimes we use it even for women who are ovulating to enhance their ovulation. We have sperm promoting procedures, things like IUI, intrauterine insemination.
Okay, yeah.
Some people have heard that referred to as artificial insemination. That's what we used to call it, and we didn't like the artificial word in that, so we made it more anatomically correct.
Okay.
Intrauterine insemination. That's where you're placing a prepared sample of sperm directly into a woman's uterus at ovulation time.
Okay.
And we have very advanced techniques like in vitro fertilization or IVF. And that's where we are using injectable hormones to stimulate a woman's ovaries to mature multiple eggs in one treatment cycle. Normally we mature one. So we ask the ovaries to mature multiple eggs. We extract those eggs from the body, and then we fertilize with sperm in the lab in order to create embryos.
Okay.
The embryos can then be placed back into the uterus, usually one at a time, and that offers the highest pregnancy rates and live birth rates that we can hope for in our reproductive technologies. So it's a very good treatment.
So just to rewind a little bit, what's the difference between, or maybe you can just clarify the difference between IUI and IVF?
So IUI will rely on fertilization in the body.
Got it. So
woman's sperm meets egg in the fallopian tube.
Got it.
As it would with completely unassisted natural conception. We simply enhance that, give Mother Nature a little push
okay.
In the right direction.
Okay.
In vitro fertilization is exactly what the words are. In vitro meaning in the laboratory.
Right.
And so that's where we are actually helping the egg and sperm to fertilize in a medical lab.
Okay. So when we talk about couples or individuals that want to conceive a child that are having challenges, sometimes the challenges are I'm a woman. I don't have a partner that I like enough to have a baby with. So I would like, I've got a donor. I would like to, so that in that case, would that be an IUI?
That would typically be an IUI.
Okay, so nothing's in the way of me conceiving naturally, but I just don't have a person.
Yeah, so that individual has a barrier to their fertility because they're lacking sperm, or perhaps they're lacking eggs.
Right.
In the case of a same-sex male couple.
Yeah, exactly.
And so we can help them source the eggs or the sperm. In the case of a person who has eggs and is needing sperm, we can do IUI.
Okay.
Sometimes we do IVF for other reasons, but certainly IUI is an option.
Okay, and I'm totally a dummy on this stuff. So can I come to you and say, I don't have any sperms. Can you find me some?
I can help you find some.
Okay.
So this is highly regulated in Canada.
Yes.
So it is legal to access donor sperm and donor eggs in Canada, which is amazing.
Okay.
But it is highly regulated.
Yes. We all saw that Netflix show of that guy that just, did you see that? You must have seen that.
Oh, yeah.
That was crazy.
Yeah.
Oh
So
my gosh.
interestingly, that's not what's regulated.
Okay.
In Canada or elsewhere.
So
you can still have a donor who provides sperm DNA for multiple different family units and may have multiple biological offspring out there. But what is regulated is we're not allowed to pay men in Canada for their sperm. I can't go out onto the streets of Kelowna and recruit young men and sell you their sperm.
Got it.
It has to come through Health Canada regulated and licensed sperm banks or sperm distributors. So there's lots of rules and regs around it that are designed to protect patients, to protect children, and to protect the donors too, honestly.
Yeah.
But there's still limitations.
Oh, wow. Yeah. Interesting. But amazing also that there's that option out there for... I know 2 women who've made that choice, and I just think, wow, good for you. Like,
we're lucky that it's legal.
Yeah.
It's not legal in all countries. Yeah.
Interesting. Now, then there's the case of the couple that has been trying for a year. In my person's case, maybe is, serious endometriosis, scar tissue, cannot carry or cannot, we always say the hallways were blocked, right?
Right.
They would come to you for IVF. And so that's where eggs harvested, sperm donated by the partner and made in not a test tube anymore, right? It's like, is it a dish?
It's a dish.
It's a dish.
Not a tube.
Not a tube. Yeah. So that's the IVF. So I was actually really surprised. I just thought it was like, oh, you go in, you take a few pills, you start to like make some more eggs, and then you go in and they take them out, and then, he goes in and has a magazine and a good time, and then ta-da! But it's not that easy.
I wish it was that easy. It's a little bit more complex than that, but it is actually easier than I think a lot of women in particular fear.
Okay.
There is still a lot of buzz about IVF and perhaps how difficult it is, and especially women worry about the hormones making them into crazy people. And I will say that I ask my patients all the time, how are you feeling? How is it going? I ask them at the end of the IVF cycle, how was it? What was your experience? For some, it was extraordinarily challenging, and they will say to me, I'm never doing that again. But for most, they actually are pleasantly surprised, and they say that was a little easier than I was expecting based on some of the things that they've heard.
Yeah. Well, you always hear the hard stories.
Yeah,
right?
understandably. But it's a commitment. It is daily self-administered hormone injections and lots of monitoring. We do a lot of regular office visits to track the progress of those egg follicles with ultrasound. The egg retrieval is procedural, so it's not like a surgery, but it is like an ultrasound-guided biopsy of the ovaries is really what it entails. Yeah. So it's a big deal.
Yeah. I'm going to just ask it, what is the success rate?
Depends on your age.
Yeah, okay.
As you can imagine. And it depends on the outcome for that individual patient or couple.
Okay.
So the younger you are, the higher your success rate. For most women under age 35, we can hope to create multiple embryos. Okay. And we can see pregnancy rates. Certainly, I can speak from my own statistics in our clinic that hover around 60% per try.
Okay.
Some pregnancies will miscarry, unfortunately, just like with natural, but the success rate of IVF is higher than it's ever been.
Amazing. Yeah. Amazing. I have one more question before we kind of switch gears a little bit and wrap up. Egg freezing.
Mm-hmm.
So I am a healthy 25-year-old. I've just decided to go back to school and get my PhD in something, and I don't have a person, and but I do want to, I've listened to a podcast like this. I'm like, all right, my eggs are as fresh as they're going to be. Tell me about egg freezing.
Yeah, do it.
Okay.
Call me.
Yeah. Okay.
I love egg freezing, and I wish more women would ask about it, and I wish it was accessible to more women. But the concept of egg freezing is that we can do the initial part of what I just described for an in vitro fertilization cycle. We can do the injectable hormones. We can stimulate the ovaries to mature multiple eggs. We can extract those eggs and then freeze them for a later date. So it is a form of, I'll say, fertility preservation. Where we have to be cautious, though, is that it does not guarantee a baby down the road. It is a way of keeping as many options open as possible. So number one choice for patients would be, if it fits your life goals and your situation, try to have your babies at a younger age. Number two option would be, if that's not possible, think about freezing some eggs so that if you experience infertility, maybe you're 38 or even 40 before you're ready, you have some younger eggs available to give you better chances of success. The biggest challenge with egg freezing is that it is still expensive. It is a high cost endeavor.
Pay to store them.
It's the process of developing and extracting the eggs that is actually the higher cost, but then you also have some annual storage as well.
And there are, I think probably the majority of your clients that would be interested in egg freezing would just be healthy younger women. But I am a breast cancer survivor. I was fortunate enough to not have to go through chemotherapy. However, I do know that for some young women that are diagnosed with cancers that are required a pretty intense interventions, they also choose to freeze their eggs so that they can have an opportunity to conceive a baby after.
They do, and we often get referrals, urgent referrals for those women with a new diagnosis, and we will get them in. I will speak to them on a weekend. We will fit them in over lunch hour, whatever we need to do to have a conversation with those patients so that they can make some informed decisions about that. And we can also make it happen right away.
Awesome.
Yeah, so we can get their eggs frozen before they start their chemotherapy, and it's a fabulous option. Yeah.
Awesome. Okay, switching gears. See, it goes so fast.
It does go fast.
I didn't even get to an entire page. I want to talk to you a little bit about, before, just as we wrap up, there's a lot in the world and in medicine and in healthcare that is just like, we hear it all the time. It's like, bad news stories. What gives you hope?
I think right now, the thing I'm feeling most hopeful about is a national thing, but also for British Columbia. Our governments are finally talking about funding IVF specifically. This is so long overdue, and it's a potential game changer. In BC, we don't have a lot of details yet. Otherwise, I would love to share it with the listeners. But unfortunately, we're still a little bit in the dark about exactly what this is going to look like. But they have announced funding for IVF, and it's coming. Just not sure exactly what form. But other provinces are jumping on board. And up until recently, really, it was Quebec and Ontario were the two provinces in our country who would invest some money into fertility treatment. And now almost all the provinces have announced something, within the last 6 months.
Wow.
And or are already doing some form of financial support for patients. So that gives me tremendous hope, at least in our field.
That is great news.
Yes.
And I would expect that there is, I mean, we didn't really talk about the socio-political impact of fertility rates dropping, but there's a vested interest on the part of politicians, both from kind of like an obvious perspective and supporting populations that are struggling with this, but also in supporting, the wealth of our country, which is its people, right? So yay. Love that. How has your we talked a little bit before we started recording about what wealthy means, at least for us. How has your definition of health changed over the years? Or has it?
Yeah, it has actually. This is a great question, and it's worth anyone reflecting on. I think anyone in healthcare reflecting on. Through my years of training, we are pathology focused. We are health care providers, but our focus is disease and illness. And I think just personally, as a human being, as a woman, and then also as a physician, I've learned over the years that might not be the right focus. And we need to change how we think about our healthcare and the importance of the health piece of the care. We know how to be care providers. What we don't necessarily do very well, in my opinion, is promote the health side. And in reproductive medicine and in infertility, promotion of the health, mental, physical well-being is huge. So I think that's how my perspective has changed over the years.
Well, that gives me hope because it's interesting. I do think it's a great question for our care providers. And interestingly, the answer is very similar to what you said, is that we're moving past kind of sick care and starting to understand what it means, what healthcare really means. Yeah, I love that. Okay. Final question, maybe. What areas of your life do you feel wealthy or abundant?
Oh gosh, I have a few, Shauna. That's not an easy question either.
That's a good thing.
But I know I'm very lucky that way. So I feel very wealthy in my personal life. I have an amazing family that all physically happens to be close by and support me as an individual unconditionally, which I recognize and value tremendously. I'm also very lucky in my professional life. I have an incredible team at work, and I've had the pleasure of working with the same core people for a very long time, and everybody supports one another in their professional worlds, in their personal lives, and in our patient care and how we approach our clinic and our patient care. And I know not everybody can say that. I know a lot of people can't say that they feel great when they go to work, and I'm truly wealthy in having that type of environment to go to every day.
Well, and it really, I think it probably has a direct correlation to the quality of care that you're able to provide do you call them clients, patients?
I call them patients.
Yeah,
I am very true to my physician hat.
Yeah.
The clients one I find hard, actually.
I know. I always figure, I don't know if there's a good word in there.
My sister often says clients, and then I very quick to correct her. You mean my patients.
Yeah. But to your point, I think that, the richness of our experiences and our health really can be distilled down to the quality of our relationships, right? And then the the outputs, right? The care that we can provide, or the service that we can provide our people that are coming to see us, it reflects that. Yeah. They're lucky to have you.
we're lucky to have one another. It's a
Yeah.
great team, and I think you're right. I think I hope anyway that it reflects in how we care for our patients as well.
I'm sure it does. I've heard very, very good things. Is there anything else you'd like to leave our listeners with before we?
My big takeaway is, please don't wait.
Mm-hmm.
Don't wait too long before you're thinking about your potential family building goals. Don't wait too long to ask questions or to seek help. I think that's the most important thing.
Awesome. Great advice. Thank you, Dr. Kathy Wise. I feel really actually optimistic, knowing that there's people like you out there that can, regardless of the choices that we make as women or as families, that there are options for us to continue to grow our families under the love and care of people who are really knowledgeable and supportive of that path. So thank you for unpacking a whole lot today, and wish you and all the people who come to see you the best.
Thanks for having me.